Basically, this will be a summary of what has been discussed. And so we know that FFR exposes the functional aspect of a stenosis rather than the anatomy. It is affected by the following parameters: epicardial anatomy, extent of the perfused territory as we have discussed, microvascular function, collaterals, and the anatomical severity is actually only just one component. And the non-hyperemic or hyperemic values determine the future course of the patient. So the validity depends on the careful steps, which are very simple: awareness of the potential pitfalls and continuous quality control of your FFR practice. So there are common technical pitfalls like the technical factors and the patient-related factors. Many of them have been discussed. So what are the 10 commandments I have divided? Basic steps should be meticulous. What are the basic steps? Prepare the pressure wire. I'm not going to the details. And calibration, that is teaching the system what is zero pressure, zeroing of the PA, that is the aortic that you are routinely doing in the cath lab, zeroing of the pressure wire or the PD, keep the wire at the level as the transducer, connect to the console and zero it. Then once you have zeroed, don't change the aortic, transducer which you have connected to the aortic pressure, because I have just recorded pressures by just raising the aortic transducer by a few millimeters. You can see the difference, because you are measuring a FFR value between 0.75 to 0.85. So minor differences will make a lot of difference. So you have to be accurate. So once you have fixed the system, you should never change the position of the transducer. Nitrates to dilate the epicardial vessels, and it should be given before introducing the wire to remove epicardial spasm. And equalization is the next step. It is teaching the two systems to be synchronous. Once you have equalized, you know that it will come to the zero, it will come to the value of 1. Catheter tip should be, you have to be meticulously careful. You have to see that if there's an ostial lesion, sometimes the gate may go inside and you may get erroneous values. Side holes, try to avoid most of the time. And somebody asked about the question, distal wire placement. This is to avoid, as Rajesh has answered, it is to avoid the problem of pressure recovery. This should be at least 2 to 3 centimeters distal to the stenosis, the last stenosis which you are going to measure. Wire position, it should be in a vessel which is freely rotating, should be in a vessel which is part of the vessel which is more than 2 millimeter in diameter. In a small vessel, it can produce a whipping artifact. Adequate hyperemia should be ensured. Central canal is preferred. Adenosine 140 micrograms, and as said, heart failure, pulmonary hypertension, you have prolonged circulatory time, so you have to give adequate time for the adenosine to act. And caffeine beverage, we have already discussed about you should avoid caffeine 12 to 24 hours prior. Posterior lesions, intravenous is always preferred, because in posterior lesions it can contribute to the stenosis. The guide catheter and partially engaged guide, adequate delivery of adenosine may not be possible in intracoronary. Measurement adequate, ensure the steps. Flush the catheter before any measurement, because your contrast will dampen the aortic pressure and reduce the aortic pressure. So you have to flush the catheter with saline before any measurement. And you have to have beat to beat variation. Some machines are programmed for a single beat measurement, which can give significant difference. So you can program it to 3 to 5 beat average. That may give a better estimate. And you should have some steady state or a smart minimum FFR. I am not going to the details, because the smart minimum FFR is the lowest average of 5 consecutive cardiac cycles, sufficient quality. That is what is mentioned. Wedging, always be on the lookout. You can see that this is a tracing of once the gate catheter is engaged, you can see that there's a significant difference in so always make sure that you pull back the gate catheter before measuring. Always pull back and measure the FFR. Very, very important. Again, another example, gate catheter engaged and gate catheter disengaged. What to do when there is wedging? Check the aortic pressure, disengage, adequate nitroglycerin, better to shift to IV adenosine, and always, I said, FFR should be assessed only after disengaging the gate catheter. And this is the most important step in a physiological measurement. The most important step. If you have not done it, you have not done justice to the patient. So always do a pull back verification. So once you have done the FFR, pull back the wire to the point where you have equalized and make sure that the value is 1. If you have not done that, you have not done a correct FFR. So the difference is less than 5 millimeter. That should be incorporated into the calculation. I will tell you an example. FFR obtained was 0.79. Your pullback PD by PS, still it was showing 0.96. It is not 1. Then you have to correct it by 0.79 by 0.96. That is 0.82. You can see that a positive one has become a negative value. So this is very, very important. And if the value is more than 5, you should take out the wire, redo the zeroing, and then redo the whole measurement. This is due to the drift, which was already discussed. I am not going to those details of drift. So this microcatheter based wires are shown to have less drift. In signal, cruise to signal, the drift has been already mentioned by Rajesh. I am not going to that again. Patient-related factors, ostial lesions, I have already said, and equalization should be done in the aortic sinus. Very, very important. And distal placement may affect the basal FFR values, in turn can affect the final values. And again, this was already shown. And FFR and ACS, there was one question. Can we, in a STEMI, the culprit vessel, we know it is microvasculature is affected. It is not recommended within almost a week's time. But during primary PCI, you can assess the FFR of the non-culprit vessel. That can be done. And culprit vessel, people say that you can do it after a few days. So again, non-culprit vessel can be assessed, even though there are some minor differences, but practically that value is reliable. Influence of hemodynamics, this is the last part I am going to discuss. LVEDP can elevate, can have assessment affect the FFR values, because high LVEDP directly impedes the myocardial perfusion, so creates a functional microvascular disease which can cause inflation of the measured FFR. LVH can also affect the FFR. Then right atrial pressure can also affect. Actually, the FFR values actually includes the venous pressure also, PD minus PV by PA minus P. So it's actual the formula. But because the venous pressure is negligible, 125, 225, we usually ignore it. But if you can see a situation where the RMN is 15, the patient is in heart failure and the aortic pressure is low, you can use that when you can see that 0.81 become 0.76. So in a patient, the patient is in heart failure or the CVP is more than 15 and the aortic pressure is low, probably you have to consider including the venous pressure also in the value. Scar tissue and collaterals, Rajesh has beautifully documented that. I will show an example. This patient had a FFR value of 0.6. Patient was waiting for the procedure, developed an MI and lost some of the myocardium. Now the FFR is 0.8. So that means that FFR corrects for the perfused territory. That is why you don't get a positive FFR in a small diagonal branch when even though the lesion looks very significant. Collaterals from the donor artery, Rajesh has shown a beautiful picture. So this RCA was 0.75. This LAD, sorry, the LAD was collateralizing this RCA and LAD FFR was 0.75. RCA was revascularized. LAD was again measured. You can see it has become negative. So LAD was applying the RCA. So that is why the FFR was positive. So to conclude, again, as I said, the validity depends on the measurement, careful training on the steps, awareness of the potential pitfalls, continuous quality control will make your measurement accurate. Thank you so much.